Hello and good. Welcome to our IVF webinar tonight. It's good to be back once again. And tonight we have another special guest, of course, as you can see. And we also have a very interesting topic. Again, we will be talking about genetics. Okay, so I hope you have some questions for Dr. Carmen here. And let me just introduce you. Dr. Carmen Morales, she is here with us tonight, and she will be talking about PGT M tonight. And of course, she will start with her presentation. So thank you so much, Carmen, for joining us tonight. And thank you already for presenting. And how are you feeling tonight? It's great to have you here.
Thank you. Hello, everyone. Thank you, Caroline. I'm very happy to be here and to be able to, or I will try to bring a little bit of light to the topic of preimplantational genetic testing for monogenic disorder. I am the genetic counselor and I'm managing the department, the genetic department in Reproclinic. It's an IVF laboratory based on Barcelona, Spain.
Wonderful. Thank you so much. And as I mentioned, it's great to have you here. And just remember that we will start off with the presentation, but afterwards, as always, it will be time for your questions. So all you need to do, just type those in the chat section, and Carmen will take care of them for you one by one. So don't hesitate. Use this opportunity to ask your questions. That's why we are here, really. And as you probably know, my IVF Answers, we are part of European Fertility Society, and we are here to support you, to answer your questions, to give you the chance to meet top fertility experts. And as you know, we have brought some of the topics to you already on various topics, actually. Yes, so tonight it's about genetics, but as you know, we were talking about egg donation treatments, we were talking about some other treatments, we focused on male and female fertility, so many of those, and it's definitely amazing to be part of it. And Carmen, thank you also again for joining us. That's great to have you here. And right now, I guess we can start with the presentation. Yes, wonderful. Perfect. Thank you so much. Let's go.
Okay, so I will talk about a test called preimplantation genetic testing for monogenic disorders. First of all, I would like to introduce what is preimplantation genetic testing. This is a genetic test that is performed on embryos that are created through an IVF cycle to detect genetic abnormalities. So this allows us to do a selective transfer of the unaffected embryos. Obviously, to do that, we need to perform a biopsy on that embryos in order to take a small sample for the genetic analysis. There are different types of preimplantation genetic testing, and they are classified based on the type of genetic abnormality they are testing or we are detecting. We have PGT-A, that is for aneuploidy testing. Previously, it was called PGS. And this test detects if the embryo has extra or missing copies of a chromosome. For example, we know that when we have an extra chromosome 21, this is trisomy 21, this is related to Down syndrome. Testing aneuploidies, it's important in a specific group of patients that they are at high risk of producing embryos with this missing or extra chromosomes. There is another kind of PGT that it's called PGT for structural rearrangement. What is a structural rearrangement? A structural rearrangement is when the quantity of DNA it's normal, there is no missing or extra quantity of DNA, but the structure of the chromosomes it's abnormal. For example, in a reciprocal translocation, we have that two chromosomes just interchange a piece of DNA, a piece of the chromosome. For example, we have the Robertsonian translocation where we have two chromosomes that are fused for the centromere. Individuals that are carriers of these structural abnormalities, they are usually balanced, they are healthy, they are completely normal, but they can experience fertility problems. These individuals can transmit this structural rearrangement and in an unbalanced form to their offspring. So this offspring, these embryos can have extra or missing parts of the chromosomes involved in the rearrangement. This can make that these embryos just end in a miscarriage, or these embryos can survive and then a baby with congenital disabilities can be born. Okay, so this test is to detect this and to avoid these abnormal embryos. And the third type of PGT is PGT for monogenic disorders. That it's the test that I'm going to explain more in detail in the following slides. In general, how it's performed, the PGT, all kinds of PGT. As I told you, we need to create the embryos in an in vitro fertilization cycle. It's preferred usually to perform ICSI, that it's intracytoplasmatic sperm injection, where you are injecting a single sperm inside the egg. Later, you need to do an embryo biopsy. That embryo biopsy can be done in day 3 or typically day 5 of embryo development, and it's just taking a small sample of the embryo. This sample is the one that is sent to the genetic laboratory, and it will be analyzed for the type of genetic abnormality we are testing that it's requested. It's very important to know that the embryos are not leaving the IVF laboratory. Okay, the only thing that is leaving the IVF that we are sending to the genetic lab is the sample from the embryo. The embryos are kept on the IVF lab. They can be cultured until they are transferred if we are doing a fresh embryo transfer, but usually since the result of the genetic diagnosis it takes several days, usually these embryos are frozen and we keep them frozen until the genetic diagnosis is ready. The laboratory is sending the genetic report to the IVF, and based on the results of the genetic report and also based on the morphology of the embryos, obviously, even if it's a normal embryo, but it's having a very bad morphology, we are not going to transfer. But based on that, we are going to select the unaffected embryos for transfer. So basically, the two main types of obtaining the sample, the embryo biopsy, this is the embryo biopsy performed on day 3. This is a cleavage stage embryo. Typically on day 3, the embryos are having 8 to 10 cells. And what we are doing here, usually with a laser or mechanically, we're making a hole in this area we have here that is surrounding the egg, that it's called the zona pellucida. We are making a hole and we are aspirating one of the cells of the embryo. And this cell, then we are putting in a tube and we are sending to the laboratory. Also, we can do the biopsy, usually in day 3, day 5, day 6, when the embryo reaches what we call blastocyst stage. It's this stage here. So we are going to do also a hole in the zona, and we are going to take between 5 to 10 cells from this one cell layer we have here, that it's called the trophocto there. And this sample is going to be sent to the laboratory for analysis. So we can have biopsies of a single cell or a very few number of cells. When the sample usually, I have to tell you that very few labs nowadays, very few the IVF labs nowadays, they have in-house their genetic laboratory. Usually they are externalizing the genetic test. Depending on the country, the IVF it's based, even they have to ship the sample abroad. Anyway, in the genetic laboratory, the sample is processed, and for the sample testing, we have different technologies available. I'm not going to explain them in detail because are very technical concepts, But the technology that we are going to use will depend on the type of PGT we are going to perform, and also the availability of the different platforms in the genetic lab. For example, the most used nowadays technology for aneuploidy screening is next generation sequencing, but aneuploidies can also be tested by qPCR or microarrays, and the use of one another technology also will be based on what is available in the genetic laboratory. So talking about specifically this PGT for monogenic disorders, this is a test that is specific to test a known genetic disorder that is affecting a family. So in theory, all monogenic disorders with a known disease-causing mutation can be tested for PGT. This is in theory. Unlike PGT-A, PGT M, it's usually performed on fertile couples that they are at high risk of having an abnormal embryo, an embryo affected of a known genetic condition, of a specific genetic condition. PGT for aneuploidies, usually it's recommended for a specific group of patients that they have fertility problems, that they are going to do an IVF, and we recommend them in order to increase their chances to achieve a pregnancy or to have a healthy baby. We can recommend them to add to the IVF treatment an aneuploidy testing of the embryos. However, for monogenic disorders, sometimes the only reason for this couple to do the IVF is to do the PGT M. We have as professionals, we have to have in mind that when we are talking to these couples, they usually had experienced the disease because they already had previous affected children. There are only other very close family members affected, or maybe one of the members of the couple is affected of the genetic disorder. And usually this test is an alternative to a natural pregnancy with a prenatal testing and eventually termination of the pregnancy in case the fetus was affected. So, but what exactly is a monogenic disorder or a monogenic disease? To put it in a simple way, let's say that we can define a gene like a subunit of the DNA that contains instructions for a specific function of our body. So mutations, abnormalities in this gene can make that this gene it's not working properly, and this can cause a medical condition that we are going to call genetic disorder. So this monogenic or single gene disorder is when we have one gene that abnormalities in this specific gene, it's causing a specific disease. Okay, one gene, one disease. And this are the kind of genetic disorders that we are going to test with PGT-M. And how these monogenic disorders can be inherited, can be transmitted through generations. Okay, we know that we have two copies of each gene. One we inherited from our mother and the other from our father. This is true for all the genes that are located in the autosomal chromosomes, that are all of them except the sex chromosomes that are X and Y. But the rest of them, we are calling them autosome chromosomes. So for all the genes, we inherited one from our mother, one from our father, and from chromosome, the ones located on chromosome X, females, the same, we have two copies, and we inherit one from our mother and one from our father, while males, they are having only one copy of these genes located in chromosome X. So depending on the type of gene, because each gene can have different pattern of inheritance, we have autosomal dominant inheritance, recessive, X-linked pattern of inheritance, or mitochondrial inheritance. So when we are talking about an autosomal dominant disease with an autosomal dominant pattern of inheritance, it means that from the 2 copies of the gene we have, if only 1 copy is mutated, this is enough to cause the disease. Okay, for example, Huntington disease, neurofibromatosis, chondroplasia, etc. For example, in this example here, we can have this man that is, let's say, it's affected of neurofibromatosis. So one of the 2 copies of the NF1 gene is mutated. Okay, so the risk for this couple to have affected children in its pregnancy is 50%. Only the ones that are inheriting this abnormal, this red mutated gene. For the recessive disorders, autosomal recessive disorder, we need to have both copies of the gene mutated, meaning abnormal, to be affected. In this example here, we see this couple, each of them, they are having only one of the copies mutated. So they are perfectly normal. They are healthy, non-affected, and they are what we call carriers, okay? But they can transmit, both of them, the abnormal copy to the offspring. So we have that 25% of their children can be affected of this recessive disorder, while all the rest will be not affected, but 50% will be carriers. So they are completely healthy, but they are at risk of having an affected child of this recessive disorder. Example of this can be cystic fibrosis, beta thalassemia, phenylketonuria, etc. Also, with its linked diseases, meaning that the gene is located in chromosome X, we have can be inherited in a dominant way, meaning 1 mutated copy of a gene in chromosome X is enough for you to be affected. So we can have females affected and males affected. Okay, and in this case, if the female is affected, she can have 50% of the offspring will be affected independently if they are boys or girls. On the other hand, in X-linked recessive, we have that males, they can only have 1 mutated copy because it's the only copy of the gene they have in the chromosome X. So if this copy is mutated, they are affected, but females, they need that both copies of the gene to be affected. This event is very rare. So usually in this kind of diseases, what we see in the pedigree is that only males are affected, while the females are the ones who are transmitting the disease through the generations. In that case, we have a non-affected carrier mother with a mutation in 1 chromosome X, and the risk of having affected children will depend if the children is boy or girl. If they are boys, 50% of them can be affected, and if they are girls, none of them will be affected. Only 50% will be carriers like her. We have to remember that man is transmitting to all the male offspring, to all of his sons, the chromosome Y, while to the daughters, he is transmitting the chromosome X. And the last type of inheritance, it's mitochondrial inheritance or mitochondrial diseases. Okay, this is quite different from the rest. The mitochondria are structures that are inside the cell, and they are the source of energy for the cells. They are essential for life. The main characteristic of these mitochondria is that these mitochondria, they have their own DNA. Each mitochondria is having DNA, okay? And another characteristic is that this mitochondria, we are inherited from our mother only, because the sperm doesn't have a mitochondria. So when there is the fertilization, all the mitochondria in the embryos are coming from the egg, so from the mother. What happened with this kind of diseases? Usually there is a phenomenon that we call heteroplasmia. Let's follow this picture here that I think it's very graphic. We have a mother, for example, with mild or not symptoms. This mother can have a mix of normal mitochondria and abnormal one. So The manifestation or the symptoms of the disease will depend on the percentage of abnormal mitochondria this patient, this mother has. Okay, usually if the percentage is less than 18-20%, we consider that this person can be asymptomatic or have very mild symptoms. If the percentage of the abnormal mitochondria is higher, the symptoms can be more severe. But what happened during the formation of the eggs, during the oogenesis, there is what we call a bottleneck effect. The mitochondria are randomly distributed within the eggs that are formed. So some eggs can have high percentage of abnormal mitochondria, and some of them very few percentage. So after fertilization, we can find embryos with different load of abnormal mitochondria. And depending on this load, these embryos will be non-affected or mild affected, or can be severely affected. So in this kind of PGT, what we are testing, it's not only if there is the presence of the mutation or not. What we are testing is the percentage of abnormal mitochondria, the load of abnormal mitochondria this embryo has. Okay, so it has been established that a cutoff of 18%. Okay, and with 18% of abnormal mitochondria, it's considered that this embryo has 95% of probability of being non-affected, healthy. Okay, so this is the cutoff. Embryos with 18 or less percentage of abnormal mitochondria can be considered for transfer. I have to tell you that this mitochondrial PGT, it's not performed in a lot of laboratories. Very few labs in the world are doing that, and it's not very frequent. According to my experience, most of the patients that they are carriers of mitochondrial disease, they opt for egg donation because for them it's an easier process. So what are the steps of the PGT? The main difference with PGT M with PGT-A, for example, is that here it requires what we call a pre-examination step. Okay, before the couple starts the IVF, we need to assess all the genetics report they have. We need to be sure the mutation that has been identified in the family, it's pathogenic, I mean, it's causing the disease, that all family members have been tested and we know who is carrier, who is not carrier. Okay, and if it has not been done, we need to request this genetic test to complete and to have the whole picture in the family. Also, we are going to choose the best testing strategy for these embryos. There are, as I told you, there are different platforms. There are different ways that these embryos can be tested. We are going to choose the best to try to test this specific kind of mutation because there are different types of mutation. Also, we have to provide the couple a genetic counseling, although in most of the cases they have a good knowledge of the disease. We need to be sure they know the risk of having an affected child. But it should be non-directive. I mean, we have to offer them all the possible reproductive options they have, that this can include natural pregnancy with termination of pregnancy and prenatal testing, obviously. This can include egg or sperm donation, embryo donation, adoption. So we have to explain them all the options they have. They have to be able to provide psychological support if it's required for the couple. We need to explain them how the IVF with the PGT M is going to work, the test we are going to use, the platforms, and the risk and limitations. And also, before starting the IVF, it's very important that we need to do what we call a preclinical workup. That is a previous genetic testing that will require family samples. Why is this so important, this preclinical workup? This is very important because in that kind of test, we have to remember we're working with very small amount of DNA, a very small sample from one cell to very few cells, okay? So there are important issues that we need to avoid. We need to avoid exogenous DNA contamination. from the laboratory staff, IVF staff, genetic lab, and this can be avoided by following very strict protocols, by clean everything, and by handle the samples and the embryos very carefully. But also contamination from paternal and maternal DNA. For example, to avoid paternal DNA, for the reason I told you, it's recommended to do ICSI, because when you are doing conventional fertilization, you can have extra sperms that are attached to the zona, and they are a source of paternal DNA that can contaminate eventually the sample when you are doing the embryo biopsy. Also, you need to minimize the maternal contamination, that is the most frequent one, by denudating very well the eggs in order to eliminate all the cumulus cells that are surrounding the egg and are from maternal origin, that can be the source of maternal DNA. But also there are some issues that are more technical related to the PCR technique that we are going to use, the amplification technique that we are going to use to be able to analyze the sample. And one thing that we call a allele dropout, that you have the mutation copy of the father and the mother, but with this allele dropout, only one of those is amplifying. So at the end, this can lead you to a misdiagnosis, because maybe you think it's affected, but in fact it's carrier, because the wild type, the normal allele, has not been amplified. Okay, so to avoid all of this, it's why it's important what we call to do an haplotyping approach. Okay, we are establishing the haplotype in the family. We are trying to search and to find the combination of what we call genetic markers that are in the surrounding area of the mutation, very close to the mutation, so close that we need to be sure that they are inherited together with the mutation. So in case there is a failure of amplification or a allele dropout in the specific mutation, we are testing other areas surrounding this mutation that can help us to give the diagnosis and to increase the accuracy of the test, because we need to reach an accuracy of the test up to more than 99%. So we need to be sure the diagnosis we are doing. And we are the combination of these markers to find these markers that are informative, that are different from the mother, from the father, etc. We need to establish what we call this haplotype, and we need to test the family members. Typically, we are testing the couple, and if they have previous affected children, but if not, sometimes we have to use the father, the mother, as affected siblings, etc. In each family, we have to assess the case, and we have to see the availability of the family members to be included. So in summary, first of all, we need to review the case to be sure that the test can be done and it's technically possible. Also, we need to do this workup to try to find to establish this haplotyping. And also, we will see if technically we can do the haplotyping, because sometimes it's not so easy. If there is a high degree of consanguinity in the couple, it's not so easy to find these markers that are informative enough. You have to go far away from the mutation, then there is more risk of misdiagnosis, etc. So in this setup, you are just not searching for these markers. You are setting up the protocol you are going to do in your lab, and you are going to establish the risk of misdiagnosis that this specific test will have, that should be very low, because if it's high, then you have to add more markers. So this is the scenario. And when this preclinical workup is finished, you see that the PGT is feasible in this couple, then you issue a report. And only when the report is ready, then the couple can start the IVF cycle. Also, after the report for the IVF cycle, the embryo analysis is ready, and there is a consultation of what we call post-test counseling, that based on the result, we have to explain the couple the result and the recommendation for transferring, if there are normal embryos, if not, also the fate of the normal embryos that they are not going to transfer, etc., etc. So as I told you before, for PGT M, there are different testing strategies and technologies. Okay, I'm not going to explain them in detail, but just to see that each laboratory can use different platforms and can approach or can design the experiment in a different way. I'm telling you this because sometimes this workup it's laboratory specific. I mean, if the couple decides to repeat the IVF in another clinic that is working with another genetic lab, most probably this workup test has to be repeated, has to be started again, because this test is lab specific. Each lab can choose different markers, can use different technology, and they need to be sure that they are going to be able to analyze this embryo with a 90% or 99% of accuracy. Okay. Also, it's important to know that this PGT M for monogenic disorder or single gene disorder can be combined with PGT for aneuploidy screening in the same sample. The same sample can be used for both technologies, but this will depend on the indication and specific for the couple. But it can be combined, and you don't need to take a second sample from the embryo. This is an example. You know that this term haplotyping, it's very complicated, but this is an example of what we have. We have here a disease. This is the gene. This is the gene with the mutation, and we are choosing some genetic markers on both sides of the mutated gene. So for the preclinical workup, we use the couple and we use an affected boy that they have, where this is what we call the haplotype. We are searching for these markers that they are in different sites. Okay, we're establishing this haplotype, and later when we're analyzing the embryos, we're able not only to test the mutation, that is this one here, the third position, but we are also testing the rest of the markers, establishing the haplotype. So what happened? For example, in this embryo, we have an allele dropout here, a failure of amplification of the region here, but this is not interfering in the result because we have other regions. We are testing several regions, so at the end, we are sure that we are giving a proper diagnosis. So, exactly what are the indications for the PGT? As I told you, this is for couples at risk of having an affected child of a known genetic disorder that is affecting the family. Okay, it can be dominant, recessive, X-linked, or the mitochondrial. And this genetic disorder has to involve a pathogenic genetic variant that has to be known and has to cause a serious condition with no cure or effective treatment. Okay, but there is another indication. Another indication is that it's called human leukocyte antigen matching, HLA matching, and this is a test. We are going to analyze the embryos created in an IVF cycle to select the ones that are compatible with a previous affected child the couple has that needs bone marrow transplantation. Okay, this is some ethical debate about that, and you know, and in some countries it's allowed, in other it's not allowed. But in general, if we're doing only the HLA matching, we can find around 25% of the embryos that can be compatible. If we are adding to that also the PGT for a monogenic disorder, because the cause of the disease in the previous child is a genetic one, the chances of finding a normal embryo for the disease plus that match with the previous baby are lower, are 1 in 6, I think, for recessive disorder, and 1 in 8 for dominant. So the chances are not very high, okay? And the couple has to be counseling very well, because this takes time. In most of the countries, you need a specific approval to do this test. Okay, when the test is approved, they have to do the preclinical workup. Then they have to do the IVF. If they are lucky and they have one embryo that it's normal and it's matching, you have to transfer them. If you are pregnant, you have to wait 9 months, because it will take long time. So you need to be sure that you know, if your son or your child is very severely affected, okay, you need to consider that you need a lot of time to achieve a sibling that can be HLA matching. So considering all of this, as I told you, this PGT usually it's for serious conditions, okay? But how serious should be a condition to be able to do a PGT M? The severity of the seriousness of a disease, can be very, it's a perception, can be very variable. Some patients with the same symptoms, they are not perceiving the disease, the disease they have the same. So it's not easy to establish what is serious, what is severe, what is not, because you know it's a perception sometimes. Also, this HLA matching test, it's, you know, there can rise ethical issues. This child is born to cure the another one, even the chances are low. What we are going to do with the embryos that are not matching but are completely healthy, okay? You know, also regarding late onset diseases, I mean diseases that the first symptoms can appear after 60 years old, okay? This person can have a very happy and fulfilling life up to them. So this can raise some ethical and controversial issues also. I mean, for example, Huntington disease. Also, we have, talking about Huntington disease, we have a test that I didn't mention before, that is the exclusion testing. It's when, for example, I put an example, it's very easy to understand. We have a couple and the male is and the man, it's at risk of having Huntington disease because his father is affected of Huntington disease, but he is still young and he's not having any symptoms, okay? But he doesn't want to know if he's affected or not because he's not able to handle it. He doesn't want to know, but he has the right to have healthy children not affected of Huntington. Okay, so one thing that they can do is exclusion testing. We are going to test the embryos, but we're not to test the mutation for the Huntington disease. What we are going to do is to see if these embryos are having the same haplotype like the grandfather, okay? And then we are not going to transfer them. We are only going to transfer the embryos with the haplotype of the grandmother, that we know the grandmother is healthy. What happens if we are doing this? That the haplotype of the grandfather can be affected or not affected. We don't know. So these embryos that we are discarding, they are having 50% chances of being normal, okay? So this test also requires a lot of counseling and analyze the case. So for all these things, what is acceptable and not acceptable, it's different in each country. Even in Europe, each country can have their different policies and regulations for what test can be directly done, what test needs to be assessed case by case, and you need a specific approval for the committee or for the national commission for that. So the law is different in each country, and this also should be explained to the couple before they are starting, because this sometimes can add time to the whole process. If before starting you need a specific approval for the government, for the law in this country, okay? So finally, I include some data from Europe that are from different surveys on assisted reproduction techniques, and we see that most of the countries that are performing assisted reproduction, PGT-A is allowed. Okay, very few of them it's bad. Okay. It doesn't happen the same with the PGT-A. PGT-A is allowed in much less countries. What it's not allowed in any country of Europe is the gender selection for social reasons. Okay, this data I include here. It's for heterosexual couples. Okay, for same gender couples, the number of countries that are allowing this test it's much lower. Also, if we are looking at the numbers of the PGT cycles done in Europe, this is data from the ESRE PGT consortium. This is the last data, the last series data published, collecting data from 2013 to 2015. We see that it's around 70,000 cycles for PGT M. And from all the cycles, they get pregnant with pregnancy positive heartbeat around 34% per embryo transfer. And if we see the type of an embryo, the type of genetic disorder it did, you see that 50% of the cases are autosomal dominant disorders, meaning that one of members of the couple was affected of this disease. As you can see here, HLA matching, it's only representing 5% of the cases. Regarding the disorders, the main disorders done in Europe, I think that for autosomal recessive cystic fibrosis, hemoglobinopathies like sickle cell thalassemias or congenital adrenal hyperplasia, for autosomal dominant myoclonic dystrophy, Huntington disease, neurofibromatosis, and hereditary cancer syndromes, and for X-linked, we have Fragile X and Duchenne muscular dystrophy. These are the main, but you know the list it's huge of diseases can be tested. So to summarize, I want to tell you that PGT-M is for couples that are at higher risk of genetic disorder in offspring, a known genetic disorder. The PGT-M is specific for a genetic condition in the family that we know the causing mutation. If we don't know the causing mutation or the causing the gene-related mutation, we cannot offer this test. The precycle examination step is essential because it will be, we are going to review the case, establish the risk, the option, limitation, the technical approach, and we are going to do the clinical workup. And as you can see, there is a great variability among countries regarding the test, the PGT test performed and the diseases that are accepted for testing. And thank you very much for your attention. I'm open to all your questions, and I will do my best to answer them. Thank you.
Wonderful. Thank you so much for this incredible presentation. Lots of details, definitely not easy topic. However, you have explained this step by step thoroughly, and definitely it's been great to find out how it works from the very beginning. So thank you so much for that, Carmen. And as you can see, there are some questions ready, some interesting ones for sure. So let's get to them, okay? Let's start with the first question that we've got. So let's see this one. Any thoughts on CRISPR in IVF?
Yes.
Sorry, not sure about that.
Yes. Well, this is for gene editing, okay? Okay, and I don't know in 20 years what will happen. Nowadays, it's not a safe procedure still. So I understand that maybe this is the future, gene editing, inserting in the embryos the healthy gene. Not for now. I think maybe it will be, yes, it will be in the future. This is still under research because it's not always working. We don't know if there are side effects. But I think this can be the future. Not for now, maybe not in 5 years, but at the end, probably will be this the future of the IVF. Instead of doing the genetic test, we are going to change the embryo to make them healthy.
Wonderful. Thank you so much for this incredible presentation. Lots of details, definitely not easy topic. However, you have explained this step by step thoroughly, and definitely it's been great to find out how it works from the very beginning. So thank you so much for that, Carmen. And as you can see, there are some questions ready, some interesting ones for sure. So let's Thank you so much indeed for your very first question, Derek. Interesting one for sure. And of course for your help with that. And let's have a look. Margie has added one more question. So when cells are retrieved from an embryo or blastocyst for PGT, won't it affect the development of the embryo or blastocyst?
There has been a lot of published studies, and there is no difference in terms of pregnancies rate and outcomes from biopsied embryos and non-biopsied embryos. After saying that, I have to tell you that the person that is doing the biopsy should be perfectly trained and very skilled. And in that case, there is no damage in the embryo. Because there are a lot of cycles done, not only for PGT M, for PGT-A, that it's more frequently done than PGT, and that PGT M. So in my opinion, about what's published and what I saw, if the person that is doing the biopsy and the conditions of the lab are good, there is no detrimental in the embryo development.
Perfect. Again, thank you so much for explaining that question as well. And let's have a look. Margie has added one more question. So could taking ubiquinol supplement 50 milligrams daily for a long time to improve egg quality affect the mitochondria in a long term?
I'm not. I'm sorry, but I'm not aware of that. I can check if she can email me. I can consult this case, but I cannot answer this question. Hello, can you hear me?
Sorry, I think you can hear me now. Apologies.
Yes.
Okay, perfect. So I mentioned that we can forward the question from Margie, and of course, I'm sure you will be able to double check it. Yes, apologies, I forgot to switch on my microphone, but I'm back. So let's have a look at the next question. So I have autoimmune disease. In order not to transfer any of this gene to my children, what test can I do to test my immune system?
Okay, not all, we don't know the genetic cause of all diseases, and not all genetic diseases are monogenic, meaning caused by defects in one single gene. I don't have more information about your autoimmune disease, if it can be single gene or not. I mean, sometimes what you found is that the couple or the patients coming to the clinic without a clear diagnosis, or they are coming because I have a child with this problem but has not been properly diagnosed. We will have a report. First of all, before starting anything, we need to have a clear genetic diagnosis. Not all the diseases, some diseases, they have a genetic component. This is obvious. For example, you have diabetes type 2 or whatever, a lot of diseases. But some diseases are not monogenic. It means it's not one gene, one disease. There is multiple genes that interact together, the combination of multiple genes, and sometimes related also with the environment can lead you a disease that it's having a genetic component, that's for sure, because sometimes they are running in families, but it's not so easy to find the genetic cause. In your case, I don't have a lot of information about your autoimmune disease. Maybe it's not monogenic disorder, most probably. And if we cannot find the genetic cause, meaning one gene, one disease, I think we cannot test the embryo. So for this reason, we will need an assessment of your case, because in case we are suspecting a monogenic disorder, meaning there are some other family members affected in your family, we see the pattern of inheritance, then there are some tests that can be done to screen all the genes that has been published that to our knowledge are related to this specific disease, to see if we can find a mutation. Unfortunately, there are a lot of genetic diseases that we don't know what is the cause. And every day the knowledge is increased, but it's not always possible. And in that case, if it's not monogenic, if it's not caused by a single gene, and a lot of diseases are not like that, so these diseases cannot be prevented in the embryos because they are not inheritable. They cannot be inherited, or they can be inherited. We don't know exactly how they are transmitted. So in that case, cannot be done. But in your case, I will need a little bit more information about your case to see if something can be done or not.
And excellent. Thank you so much once again for your thorough answer to yet another question, and of course for your question indeed. And as Carmen mentioned, if you would like to get some more details from Carmen and her team, you can contact Carmen. I'm sure they will be more than happy to help you out. And let's have a look at the next question. So SCNT, I'm not sure about that one as well, sorry, to fix PGT M. Are you doing this in your country?
I don't understand exactly what this.
Derek, is there any chance you can type us in what's the shortcut for
to fix PGT M? Via to fix. I don't know what's the meaning of the sentence. Via to fix. PGT M, it's not fixing anything, or it's not fixing any disease. It's only a genetic tool to tell you these embryos are affected of this disease or are unaffected, and then based on these results, you can choose to transfer the unaffected ones. Okay, it's not that you are going to change the embryos in any way. I mean, you can have all the embryos abnormal, and then you are not going to be able to transfer anyone. This can happen. This is so with the PGT M, we are not fixing the embryos. We are breaking the embryos, and we are telling the couple these are unaffected and these are affected. So the ones that are unaffected can be safely transferred. Okay.
All right. Thank you so much. Of course, Derek, if you would like to add something, just go ahead. Okay. And in the meantime, let's have a look at the next question. So PGT-A is allowed in Germany without ethic vote like PGT M?
I don't think so. The last review I found, it was all policies in Europe, European countries, from I think at the end of 2018. But I think in Germany, PGT-A, to my knowledge, unless they have changed it recently, it's not allowed. PGT-M is allowed, but the case should be assessed case by case, and there is an ethical committee that has to review the case, and it should be done case by case. For PGT-A, I don't think so. If for PGT-M is so strict, I don't think that for PGT-A it will be more permissive. Usually it's the other way around. PGT-M, since already these couples, they have the option to do a prenatal testing with a termination in pregnancy in most of the countries. It's more widely accepted than PGT-A, that in some countries it's not considered that some aneuploidies are severe enough, or the PGT-A is more controversial. So I to my knowledge, no. But well, it can be easily checked.
Understandable. Thank you so much. And just to confirm, so PGT-A is not allowed in Germany, right?
To my knowledge, no.
Okay, of course. Perfect. Thank you so much. And at least for now, it might be our final question. But of course, if you have any left, you know what to do. Go ahead, type those in. And there's a thank you from Margie. And the question here we got from Lisa: how many monogenic diseases are there?
Thousands. I mean, there are a lot. So some of them are more frequent than others for different kind of effects. For example, cystic fibrosis is quite frequent in Europe population, sometimes because of a founder effect. I mean, or we have a common ancestor that was having this mutation, or for any kind of reason having being a carrier of this mutation has been preferably selected in this population because, you know, it's beneficial for something else, whatever. Or in some island, only one person travel with the mutation there, and then, you know, this is like the common ancestor of a lot of people. So more, some genetic diseases are more frequent in some populations than in others, or populations with a high level of consanguinity. Okay, you can find specific genetic disorders in this population that you cannot find in another one. But there are thousands of genes, and most of them can suffer mutations. Some mutations, can happen sporadically. I mean, most of the diseases are inherited, but some patients, they have the mutation de novo on them, meaning they, for example, in achondroplasia, some patients, the fathers are healthy, completely normal, and they have a child with achondroplasia because a de novo mutation, a mutation has been produced new in this embryo. But from now on, this person can transmit the mutation to the offspring. Okay, so how many diseases are? Thousands. Okay, so for this reason, it's very important to assess each case, because sometimes the diseases are very rare and you have never seen them before. You have to check, to assess the case, to see the mutation. Some of them, they detect a mutation, but if it's pathogenic or no, it's not quite clear. In that case, it's not recommended to do PGT, etc. But there are thousands of genetic disorders. All the functions of our bodies are regulated from a gene. So the genes, we have thousands of genes. So eventually they can cause a genetic disorder, all of them.
Again, thank you so much indeed for explaining that. And let's have a look. One more question that we got from Daniel. Can I travel into PGT M overseas if it's not allowed in my country? Will the laboratory help me?
Yes, definitely. We are in Reproclinic. We are specialized in patients from abroad. Okay, so yes, there is no problem. If you are interested, you can send me an email, and we can provide you all the information. The clinic will help you. We are, because depending on the country, with visa issues and these things, and we are going to explain the whole process. And yes, for sure.
That is great to hear. Thank you so much indeed. As you can see, there's a thanks from our patients for you for answering all the questions. It looks like that was our final question. So thank you so much, Carmen, for explaining all the details. It's been lovely to have you here, and I think it's been very, very useful to all of you. So thanks a lot. And of course, thanks to everyone here that joined us simply for your questions. And I do believe it's been useful to you. And, we are doing this. We are here every day just because we want to support you. So I do hope that you found it useful as well. And is there anything else, Carmen, that you would like to add before we finish?
No, just thank you very much for this opportunity to be able to explain this. I know these are complicated topics sometimes to understand, but especially when the couple, they are suffering from this genetic disorder, or they have it's confusing, but they have knowledge. And for general population, I understand that sometimes it's difficult, but step by step, I think, bringing some light to these topics, it's good also.
Yes, so definitely. I'm very happy that we are bringing those topics, and we will discuss also, just so you know, Carmen will be back next week. She will talk about PGT-A. Right. So if you haven't signed up yet, go ahead, do it. OK, Carmen will be back with one more topic. So I'm sure it's going to be interesting for you as well. And of course, remember, this has been recorded. So anyone, if you wish, you will be able to simply have a look and check it out. And of course, as you can see, great presentation. Thank you from Margie for you. And this webinar will be available on our site tomorrow and also on our YouTube channel. channel. So go ahead and subscribe to our YouTube channel. That way you will be notified that the video has been uploaded, of course. And again, thank you so much. It's been great to have you here, Carmen. I'm very happy that we will see each other next week. So see you next week then, right? We are having the webinar on Tuesday, right, as well. So perfect. Thank you so much. See you soon. And everyone, have a lovely evening. And I do hope to see you back here. We will be tomorrow at 8 p.m. UK time. Thank you so much. Take care. Bye.
Bye.